talking about the symptoms and stuff, they put this arrow up and down question, which is very important. What's the exact problem with Klinefelter? Dysgenesis of that seminiferous tubules. Those tubules were not developed properly. Therefore, they cannot secrete inhibin B. Usually what happens that seminiferous tubule secretes inhibin B. That inhibin B goes to your pituitary and inhibit the FSH because they are getting a negative feedback. Is that clear, folks? Now, when you have a dysgenesis, that means you're not getting a negative feedback. Decrease inhibin B, which will increase the FSH. FSH is going to keep stimulating because they are not getting inhibin B. So that's number one. Is everybody clear, folks? Next, they also have abnormal Leydig cell functions. We just talked about it. What does Leydig cells do? They produce testosterone. They have decreased testosterone. Therefore, they are not getting a response, so LH is increased. The only way to inhibit LH, usually testosterone will go and inhibits it, but here you don't have it. So to summarize, I'm just going to put decrease testo, decrease inhibin B, and then increase FSH and increase LH, in one line. This needs to be memorized, folks, because they will put the question arrow up and down, and you don't want to get confused at that point. So that's the idea, okay? That's a problem there. Now, these people have a small firm testis, infertility, tall economic proportions and stuff, gynecomastia, female hair distribution. They have one extra X chromosome, inactivated X chromosome. We call that bar body, folks, okay? These people are they live a normal life. The only time they find about this when they do a workup for infertility. You see, we will talk about that a little later. Infertility is defined as 12 months frequent intercourse. Still, they did not become pregnant. The female did not. That's where we infertility. Whenever the infertility diagnosis is made, male get tested first. At that time, they find out those things, folks, okay? Increased risk of breast cancer, but more than that, that's the idea. But for me, this chart is considered super high. You need to know that, folks, in and out. So that's Klinefelter. Is everybody clear, folks? Okay. Next one. Turner syndrome. We talked about Turner syndrome many times. When we say Turner syndrome, two things should come to your mind right away. Coarctation of aorta. What's the other one? Bicuspid aortic valve. Okay. That's that. Now look at this here. 45X. Oh, there's a chromosome missing here. These people are short. They have this, what is it called? Ovarian dysgenesis. Oh, look at that. When you have ovarian dysgenesis, what we call streak ovary, the question is, do they have enough estrogen? No ovary, no estrogen. Very good. That's important. Okay. Broad chest and widely spaced nipples, bicuspid aortic valve, and coarctation of aorta. So we know that already. These people have a web neck, right? We call that, it's a lymphatic defect resulting cystic hygroma. So the lymphs around the necks are underdeveloped. So that's kind of give that enlargement, that web neck, folks, okay? And they also have Horseshoe kidney. Now, Horseshoe kidney is a disease, I assume you guys know, it's a very common, where the inferior pole of the kidney is fused. The inferior pole of the kidney is fused. Is the kidney functional? 100% functional. There is nothing wrong. The inferior kidney is fused, okay? So that's called Horseshoe kidney. Now, when you talk about Horseshoe kidney, there's only ask you one question. During embryology, kidney is formed on the lower abdominal cavity and they have to go up. But when they have a Horseshoe kidney, they cannot go up because there's a blood vessel coming on top of it. It's preventing. And you need to know what that blood vessel is. It's inferior mesenteric artery, okay? So that's inferior mesenteric artery. All right. So that's the idea. This is a most common cause of primary amenorrhea, and they don't have no bar bodies and stuff. Look at here, folks. Menopause before menarche. So the idea is these people don't have ovary or didn't develop ovary. When there's no ovary, decrease estrogen, which will increase LH and FSH. Okay, so that's also, you have to be careful here. No estrogen. Sex chromosome X or rarely Y, or loss often due to non-disjunction during meiosis or mitosis. Okay, so that's important. Next, this line. They actually gave a Turner syndrome as if she can become pregnant. She doesn't have ovary, but does she have uterus? Yes or no? She has it because she has nothing wrong with Mullerian duct. Is everybody clear, folks? So she can. The only thing is you have to give them estrogen from externally. Pregnancy is possible in some cases, IVF. Only thing is exogenous estrogen and progesterone has to be given. Is everybody clear, folks? So a student who took the step 1 exam, she actually told me after the exam, Turner syndrome, they gave a Turner syndrome as what is, if she can have a baby, and if she does, what's the method? So the student was looking for IVF. She said the IVF option was not there. Then there was another option, surrogate pregnancy. Now, remember, folks, IVF she can, but since in the exam they didn't give IVF, you have to go for the next best option, which is a surrogate pregnancy. Is that clear, folks? So you have to get pick the right on the options, okay? So it's either IVF or surrogate pregnancy, folks, okay? So that's Turner syndrome, okay? Now that's what you need to know for it. Now, let's go here. This is a very low yield, just to kind of know double
Dr.
Y males. Yes.
Can I ask a question? For Turner syndrome, if they don't have ovaries, even if you give estrogen, are they going to be making their own eggs?
No, somebody
Right,
has
okay.
to give egg
So they have
transplant.
to use an egg donor.
Yes, you need
Okay.
an egg donor.
Okay, thanks.
Okay. Now, double Y males. This is a 47XYY. Okay. Phenotypically normal. What does that mean? Phenotypical mean how they look. Okay. Genotypical mean what's their chromosomes. Here they are normal, underdiagnosed, very tall, normal fertility, may be associated with severe acne, learning disability, autism spectrum disorders, possibly. Very rare disorder. You just know the name. I wouldn't be worried about this, folks. Okay. Now, go to this page. All the diseases are super high yield in this page, folks. Those 4 diseases. I'm going to go from high yield to low yield. Kallman syndrome, 100%. Okay. So, talking about Kallman syndrome, it's failure to complete puberty. Okay. Failure to complete puberty. It is a form of hypogonadotropic hypogonadism. Defective migration of neurons and subsequent failure of olfactory bulb to develop. So even though their problem is decreased GnRH, so you should know the normal function, right? So GnRH stimulate LH and FSH, isn't it, folks? You need LH and FSH to stimulate the ovary for everything else. But if this is decreased, everything is going to be decreased. Is everybody clear, folks? That's a problem here. Number 2, failure of olfactory bulb to develop. What's the function of olfactory? Smell. So these people will have something called anosmia or hyposmia. They cannot smell anything. So you cannot miss this question. It is a reproductive question with a loss of smell. It's like an Alport syndrome we did yesterday with the kidney problem and hearing loss, right? So this is very easy to pick, folks, okay? Olfactory problem. Look at this, decreased GnRH, FSH, LSH, and testosterone. All of them are down. So you have to know that, folks. Infertility. Okay? So that's Kallman syndrome. Next, 5-alpha reductase deficiency. We just studied what does 5-alpha reductase do? Convert testosterone to dihydrotestosterone, which is important for external male genitalia, including prostate. Is that clear, folks? All right. When they have the deficiency, it is autosomal recessive, but this is limited to genetic males because here we are only talking about males, folks, okay? Inability to convert testosterone to DHT. Atypical genitalia until puberty. Remember, I was mentioning, if you cannot get DHT, they cannot get the development. But after puberty, they get more testosterone that gives you masculinization and growth of external genitalia. So they become normal after puberty, folks, okay? They become almost normal. Testosterone, estrogen levels are normal. Everything is pretty much normal here, folks, okay? So only symptom is until puberty. After puberty, they grow back, okay? So that's 5 alpha reductase deficiency.
Does the testosterone activate the enzyme again?
Say it again?
Testosterone activate or do something to the enzyme that is deficient?
No. So basically, your adrenal gland can produce the DHT, also the active form of dihydrotestosterone. So that's why even without the enzyme, they're okay with that. And then also higher testosterone can also work on the muscles directly. Next, aromatase deficiency. Now that brings you to learn what's a normal function, okay? So we have fat cells, adipocytes. Okay, so these are adipocytes. The more fat cell we have, the more aromatase we have, aromatase. What does aromatase do? It takes the androgen and convert it to estrogen. Okay, we take the androgen and convert it to estrogen. That brings you to a topic. The more fat cells we have, the more estrogen we produce in the body. Is everybody clear, folks? This is very important, because the more fat cells mean more aromatase, more estrogen. Estrogen is bad when they're higher. It can cause endometrial hyperplasia and all those things. Here, you have aromatase deficiency. If you have aromatase deficiency, technically, we cannot produce enough estrogen. Is that clear, folks? Now you could see here, inability to synthesize endogenous estrogens. Okay, we cannot produce estrogen, autosomal recessive. During fetal life.
What are the negative effects of estrogen that you told?
Say it again.
What are the negative effects of estrogen?
We need estrogen for the development for the ovaries and also, uterus and everything. Without estrogen, we cannot do that because it's a hormone that needs it.
If there's increase in estrogen, what happens?
It's not negative. So if you have excess amount of estrogen, you will have endometrial hyperplasia. Okay, one of the part is endometrial hyperplasia. We will talk about endometrial hyperplasia and I'll mention that again. DHA is produced by fetal adrenal glands but cannot be converted to estrogen by the placenta and is converted to testosterone peripherally, folks. That's a problem here, okay? So when they don't have aromatase, they do that. So you should know whenever there's an aromatase deficiency, you have more testosterone in that case. All the androgens are being converted, folks, okay? Now, that more testosterone gives you virilization of both female, infant, and the mother, okay? So because it crosses the placenta and stuff when you have it. Last one here, androgen insensitivity syndrome. There's a defect in androgen receptor. So keep in mind, it's not the problem with the hormone, it's a problem with the receptor. So you have enough amount of androgen, but it's not responding in the receptor, resulting in female appearing genetical male. What does that mean? Phenotypically, it's female. Genotypically, it's male. So they look like a female, but they carry male. Is everybody clear, folks? All right. So that's the idea. So female external genitalia with the scant axillary and pubic hair, rudimentary vagina. Basically, the vagina is not fully developed. That's what it is. Uterus and fallopian tubes are absent due to persistence of anti-Mullerian hormone. Remember, folks, even though this person looks like a female, they are carrying the male gene. That means this Y will activate MIF. Does that make sense, folks? That MIF will inhibit the Mullerian. So she won't have proximal vagina, no fallopian tubes, no uterus. Is that clear, folks? All right. So important. Patient develop normal functioning testes. They are often found in the labia majora, folks. We remove it to prevent this malignancy. Usually you are removed to prevent the malignancy, folks, okay? So that's that. That's androgen insensitivity syndrome, increased testosterone, estrogen, and LH. All of them are increased, okay? So that's this section. Let's do some question in what we have just.